So thank you, Daniel and Duke, for coming today. Daniel is a host and producer of the award-winning Talking Type 1 podcast, and he also works in HR. Thank you, Daniel, so much for being here with us today. And Duke is a spoken word artist and hip-hop artist who has a new single coming out today called Searching for Home. We're going to be having a conversation about what it's like to live with type 1 from minority and diverse community perspectives. First question I'd love for you to kind of talk to us about is just what it's been like for you living with type 1 and how that's interacted with your full identities and other things that you've experienced.
Thank you. So I've been living with type 1 diabetes for coming up to 28 years. I've had a very mixed relationship with the condition, really struggled during my teenage years, just trying to fit in, doing what my friends were doing, but obviously I had type 1 diabetes in the background. As I said, I really struggled, and that struggle, now when I look back, I was experiencing diabetes distress and diabetes burnout. I also had a really bad transition period from paediatric care to the adult clinic, and I got to a point of thinking to myself, well, if they don't care, why should I care? All I need to do is take insulin to stay alive. And that was kind of my mindset for managing my type 1 diabetes for a number of years. For me, and just going back to the question about identity and being a black man living with type 1 diabetes, I think I've never, well not never, but few and far between seeing people who look like me and having that representation of type 1 diabetes. And even to this day now, I think there are very few of us who are out there. And that's key as well. There's also, and it's very multi-layered, so there's the cultural aspect of type 1 diabetes and coming from a Caribbean background and not talking about health.
Yeah, so my story sort of starts actually when I was about 12 years old. So I began to experience horrifying intrusive thoughts, which I really didn't understand and were quite frightening. So I've got OCD, obsessive compulsive disorder, a heavily stigmatized and misunderstood mental health condition. And I felt the need to perform something called compulsions repetitively to ensure those horrible things would not happen, which sounds completely irrational, and it is irrational. And the reason why I'm telling you this is because when I was 23, I was diagnosed with type 1 diabetes when I was 23 years old. You know, I still have OCD to this day. I still live with both conditions. But when I got diagnosed, they sort of collided with each other. OCD is all about numbers. So like there's an intrusive thought attached to like all numbers, hence why you perform compulsions a certain number of times. So a good number for me, for example, would be 20. So you perform a compulsion 20 times, but you're always left with something that we can never escape, which is uncertainty. With an insulin pen, you've obviously got numbers. When you dial up when you dial it up.
Yeah.
So I would either, when I first got diagnosed, I would either just not inject insulin because it was just easier just to not inject and deal with the intrusive thoughts, or it would be like a number that I didn't like, so I would either give myself too much insulin or I would just inject too little insulin and allow myself to just go high.
That's really fascinating, Duke, and not something that I had ever considered before I'd heard you talk about it. From your experience then, it'd be great to know why for you it's such an important topic for healthcare to consider the full needs of an individual and think about minority experiences and minority needs as well. So
I think it's extremely important to see the person, treat a person holistically, the whole person. As I said, type 1 diabetes and OCD collided with each other. It was difficult to combat both conditions. So, you know, I'd go and see my diabetes consultant and they would tell me X, Y, and Z that I had to do, but they wouldn't quite understand that that would affect my mental health condition. So it was kind of tough. It was kind of tricky to sort of battle that. You know, nobody's just going to have type 1 diabetes. They're going to have something else that's going on in their lives.
I was diagnosed in the late 90s, and the conversations that were taking place between my healthcare professionals and me at a very young age were, looking back, quite brutal. So it would be, if you don't look after yourself, then this will happen. If you don't look after yourself, then that will happen. Very much using scare tactics. And as I've progressed through kind of life, it's always felt that my type 1 diabetes is just the numbers. And when I have a meeting or I go to an appointment, there's always just the focus on the numbers. And actually just sitting down and saying, how are you? makes a big difference. And if I compare that care to, so just for transparency, I had a kidney transplant in 2018. If I compare my diabetes care to my kidney care, two completely different experiences. My kidney team treat me as a whole person. I had a family bereavement earlier on this year, and they were so understanding about that and understanding how that impacted me and how I kind of fell off the wagon a bit with my management. But they has created such a safe space for me. I was able to speak to them quite openly. In comparison to when I went to my diabetes clinic, it was, well, your time in rage isn't that great, it's not good. And only after had my consultant read the letter and seen that I had a bereavement, said, oh, you had a bereavement. I was like, yes. I'm more than just data. I'm not a data churning machine. I'm a person. Type 1 diabetes, the physical side is much easier than the mental and emotional side.
I would really love to know if there's a good example that you've seen of where healthcare has taken account of those factors, has been inclusive, has really thought about the needs of all patients and all people living with conditions, including diabetes.
So I recently saw that NHS England had did a project with barbers in Islington, and that was the barber, one of their clients recently had taken their own life, and so NHS England had partnered with the barbers to provide the barbers with the skills to notice the signs if anyone is feeling signs of depression or thinking about taking their own life. And that's important for me because when we talk about the cultural side, it's understanding how important, say, the barbershop is as a black man. That's a community hub for many, many black men. Looking at that was an example of meeting people where they are and not expecting people to come to you. So I really, really like that example from NHS England.
So I live in Wales, I'm from Cardiff, and this year I worked with the Arts for Health and Wellbeing team, and we did a 10-week workshop with young people living with type 1 diabetes. So the workshop was all about helping them use sort of writing and poetry as a bit of a self-therapy and a bit of art, just to sort of understand their condition, write about how they feel. They had the opportunity to talk about stigma, especially in school, because a lot of young people are quite nervous in school to even inject or tell people about their diabetes. It gave them a voice, it gave them a little bit of a peer support group, a community, and gave them hopefully some sort of poetry skills so that they could write about their condition. So that's a fantastic thing, which was a combination of arts and, the hospital.
Great, thank you. And both such great examples of thinking maybe slightly less traditionally about how we deliver care and how we bring in other elements. So brilliant. It'd be great to know what you think needs to change to support trust in our health system, in our relationships with our healthcare professionals. If there's anything you'd highlight, and also what success looks like for you. Is there something that if you think about what it would mean if we got this right, what would that look like?
I think for me, so I've done a lot of work sort of in the arts and working with different various people who are struggling, for example, substance misuse, dementia, stuff like that. And what often comes up is that the NHS are almost divided in their categories. So what I'm saying is, in terms of diabetes, psychologically, which is just my experience, is just the psychological team talking fluidly with the diabetes team and just becoming one. And I think that would just really improve people's lives, especially if they're experiencing burnout.
So for me, success looks like something that we've touched on earlier. Is about seeing the person as a whole person living with type 1 diabetes, having that cultural understanding of what that individual's going through. So for example, up until Carbs and Cows recently released the World Foods Book, I would have to be winging how to take insulin for cultural foods. And that shouldn't be the case for me, because I'm having to use a system that it should be there to help and support me, but I don't have the culturally appropriate information there. I think there are many people in this room where you'll have people in your clinics who will want to be advocates and will want to help others like us, and tapping into those people and getting them to try and to want to help other people living with type 1 diabetes, because we all know, people living with type 1, what it's like. And I think fundamentally we all want to help each other.
That's great. Thank you so much, both. I think it's been a really, really great conversation. So thank you very much, everyone. I'm really, really pleased to be joined today by Dr. Sufyan Hussain, who's a consultant diabetologist and honorary senior clinical lecturer at King's College London, and also Maddie Julian, who's the chief executive and co-founder of DigiBeats. The first question I'd love it if you could tell our audience about is just how your lived experience with type 1 and in the type 1 community has informed your work.
So I've lived with type 1 for 33 years. First 10 years of which was spent in a third world country in Pakistan. Those experiences, those early experiences, were quite fundamental in shaping my perspective of the differences in culture and understanding, education, and the emphasis that comes into it with managing type 1 diabetes. And then having moved here, seeing the transition of care and where it's got to at different stages was also quite key in shaping my perspective. So now as a healthcare professional, as an academic, it's certainly the issues around diversity and equity are really key and fundamental. And my mantra is always about trying to ensure that we can get the best possible treatments in everyone's hands, and maintaining that equity is very important, which I'm sure we'll discuss.
I'm Maddie Julian, and I'm CEO of DigiBeat, and I'm co-founder as well. I set DigiBeat up as a result of our son being diagnosed at 20 months about 8 years ago now. And really my passion is about making resources age appropriate, accessible, to enable all of our young people in different cultural contexts, but also with their learning needs and learning styles, able to access healthcare, understand their healthcare, and be able to get the same outcomes as everybody else.
From your perspective, do you think the current care landscape is well adapted to diverse communities?
You know, we know there's room for improvement, but before we talk about the negatives, actually talk about the positives. Having just come back from ADA, the American Diabetes Association conference, I think the UK certainly leads the landscape in terms of promoting equity. We have a free model of healthcare, and that does help solve a lot of the things that I see a lot more of happening across the patch, even in Western countries and Western Europe. So I also have a role with International Diabetes Federation in Europe, and we see, again, inequities a lot more there. Having said that, we clearly know, and we're here today, that there's still issues that we come across in the National Health Service, despite supposedly having a free healthcare. And we see these issues happening in terms of the areas that I certainly focus on are on the impact of socioeconomic deprivation and the impact of ethnicity in terms of your attainment in healthcare. Not just access, but also in terms of attainment.
From my perspective, I think, we are very, very lucky to have the NHS, to have the setup of diabetes networks that are working so hard to improve everybody's care across the country. We have a diabetes program. We have now digital standards, which mean that resources like ours have to be accessible to everybody because of the DTAC. I'm a dyslexic teacher, and when we got the diagnosis, we got given a textbook, and this is the starting point. And I think for lots of conditions, wow, you've got this diagnosis and you're given a textbook, and then you've got to try and understand the textbook. And, I'm a MA graduate, so I've really overcome a lot of my barriers, but I thought about all the families that I taught with, huge number of kids, diversity, and, lower economic status, not being able to put food on the table. Their priority is not going to be to how to understand this graph. So I think that's the context in which we work, and we have to improve on, even though we are doing really good stuff in the NHS, but actually, how do we personalise healthcare? How do we make it accessible?
In terms of the barriers to doing better, or the barriers to improving the accessibility of our care, the accessibility of services, what are some of the things that you see or you've experienced?
Things like siloed working, not sharing good practice, because there's already good stuff out there that we need to link up, and if we all do our part and we link together, we have such a much bigger impact. So there is some really good practice, but it's sharing that and implementing it as well. So, you know, seeing that you'll deliver a session and you'll train people and then they don't implement it, it's quite disheartening. But you have to keep pushing through, and you have to use the data to say, look, this is what we're doing in this area, and this is working. If you could do this, then you could make it work too. So I think probably some of the barriers are there. I think other barriers are things like actually the cost of, say, translating the resources. So you have to really think about how we're not going to date these resources, how they can be kind of evergreen and live on.
From my experience of working in diabetes technologies, the first barrier is, you know, when you put up any guidance or any aspects around eligibility, it ultimately creates potential for a barrier to be formed. And this is where the inverse care law comes in. This was something proposed over 50 years ago in the NHS, that the high-cost treatments are often accessed by those who may not necessarily be the ones who most need it. And in that ties in socioeconomic status, health literacy that drives it. So the moment you put some form of a guidance around eligibility criteria, that can ultimately create disparities. So CGM, a great example. We don't have any barriers now. Everyone with type 1 can get access to it, and that's eroded a lot of those barriers. But the moment you have a criteria, it can lend itself towards that. Other things Maddie's already alluded towards about understanding, education, but even cultural aspects. So with technologies, again, the stigma of wearing devices, the stigma of the identity of having diabetes also comes into the mix. And then the healthcare professional understandings about or being able to appreciate these issues and barriers and how they overcome those issues, how they understand the culture, becomes really important as well. We know those barriers are still there despite being a free service, and there is still a big part of our perceptions as healthcare professionals where we may form judgments about who may be able to make best use of a particular treatment in our minds, and trying to overcome those and understand that actually there's a lot of benefit that can be gained.
What change do you think we can most easily make? If tomorrow we were going to go out tomorrow as a community and make one change, what are the big changes you think we can make most easily to drive improvements for our whole community?
Look for what is already out there before you start trying to do your own thing. Look at what good looks like, and turn to, especially when we talk about the technology, turn to the DTN, turn to the Diabetes Technology Network, have a look at what they're producing, certainly for adults. And also, I think listen to the young people or the patients that your community that you're serving. People have context in their lives; they have things happening in their lives, and diabetes just might not be a priority. If we can ease any of the burden of that, then diabetes may become their priority, and that's what a lot of young people talk to me about.
Developing your champions, particularly champions with diabetes, to help ensure that the cause or the messages you're trying to propel to certain communities does filter across. Also, always have that critical view of looking at your data to see where your gaps are, what's happening in your services. So we want to try and understand how we can improve ourselves and potentially learn from our own experiences and help others as well.
Is there something that we as industry can think about doing to support this conversation and support this change?
I mean, from a children and young people's point of view, we've been talking a lot about schools and the challenges young people have in schools. Care doesn't stop at the gate of a school, unfortunately. As we send our children into school, we worry about them as parents, but also they worry about themselves too. And lots of the filming that we've done with young people, again and again, they say, I worry when I'm low, I worry someone's going to be there for me. So, how do we extend that model in the ICES to include those schools, to make sure that care is a continuous loop? And to support the system in policy, really. We need to look at the policy of young people and prioritising them and long-term conditions in the school system. So I think that's something that I would love, and I think we are going to be working on.
Learning from our examples, let's say, of COVID vaccine hesitancy, which communities were the ones where that was felt the most. And now understanding why that may have happened. Again, trust is a big part of why that aspect happened. So if we are going to redefine trust, it's also about ensuring we engage with those communities right from the start in the research phase. So again, thinking of Sanofi and the research it's doing, how do we ensure we include those communities that are currently not included in the trials in the studies right from the start? How do we make sure that they're included, we understand their perspective as well? And that element is going to be absolutely key moving forwards, not just in Sanofi's example, but in every treatment example.
There's been a most fantastic thing that's happened in the Northeast, and where they've been doing some poverty proofing study, which won a HSJ award, and they trained all the units across the Northeast in terms of poverty proofing. We've just heard they're going to be rolling a lot of that out, and the training across the country. They're really tangible quality improvement programs that will help patients, and they don't cost a lot of money, but they will make a huge difference because it's understanding that context.
Amazing. Thank you so much both. Really great conversation.